Hi, Dr. Ferrer. Are you okay to get started?
I am.
Wonderful. Good afternoon, everyone. Thank you so much for joining the Los Angeles County Department of Public Health today, March 3rd, for a media briefing. Today, we have the Director of Public Health, Dr. Barbara Ferrer, and Los Angeles Board of Supervisors Chair, Supervisor Holly J. Mitchell, presenting. Both Supervisor Mitchell and Dr. Ferrer will then take your questions. Please remember, if you'd like to ask a question, please use the hand icon, or you may chat me, the host. Dr. Ferrer, you'll be beginning the remarks today.
Yeah, thank you, and good afternoon, everyone, and welcome to today's briefing, where I'll provide a status update, discuss how we're adjusting our local mitigation strategies based on new state and federal guidance, and obviously respond to questions. Specifically, I'll share our current metrics on cases, hospitalizations, and deaths. I'll walk you through the core components of our post-surge plan for LA County and present our first community levels metrics summary. I'll share changes to our health officer order and the current requirements for masking in schools. I'll talk about the county early alert signals and share actions we can take when we identify concerns and discuss components of our preparedness efforts. Finally, I'll close with a reminder of why it's still important for us to reduce COVID-19 in LA County. I'll take the first slide. We're now several weeks out from noting the end of our devastating winter surge, and I'm pleased to share that our situation and many of our metrics have continued to improve. While we're not yet at our pre-surge levels, we are making very good progress. As our metrics continue to improve, we'll continue to make sensible changes to our mitigation strategies, guided by the county's post-surge plan that is anchored in both the state's and CDC's updated COVID-19 frameworks. The work will continue to focus on reducing the risk of COVID-19 for all residents and to narrow the gaps that leave some communities and residents significantly more vulnerable to COVID-19's harmful effects. Given the unpredictability of COVID-19, we're also focusing on preparedness so that we'll be ready to swiftly tailor our response options in the event of a new variant, a surge, or another challenge. Before I discuss our post-surge plan, I'll start with a look at our customary metrics over the past week. While COVID-19 still poses a risk for many across the county, our metrics are much improved. Over the last week, cases and test positivity have once again declined. Today, we're reporting just about 1,600 new cases. The average number of daily new cases reported over the past 7 days has declined to an average of about 1,700 new cases from about 2,400 cases the previous 7 days. Our 7-day average daily case rate has also declined to 17 new cases per 100,000 residents. Our 7-day average daily test positivity rate has also declined to 1.2%, which means that 1 out of every 80 test results reported to us were positive. Compare that to 1 out of every 4 at the beginning of the year. Our hospitalizations, which, as you will see, are a key component of CDC's measure of community risk, have continued to decline, and today we're reporting about 300 fewer hospitalizations than last Thursday, with 852 people currently hospitalized with COVID-19. Our daily reported deaths have stayed consistent at an average of about 55 deaths per day over the past 2 weeks. I'm also very sad to share that this week we're reporting the death of a teenager, which brings the total number of deaths among children in LA County to 10. This, like all deaths related to COVID-19, is a tragic loss, which will have a profound impact on this child's family and friends. I send wishes for peace and comfort to the family and to all others who are grieving the loss of a loved one to COVID-19. Next slide. As mentioned today, I'll be walking you through our newly released Los Angeles County Post-Surge Response Plan, which can be found in its entirety on our website. At the center of this are a set of equity-focused post-surge actions that are aimed at protecting the most vulnerable, including those at risk of experiencing elevated rates of illness and death from COVID-19, protecting hospitals and health systems functioning, preventing unconstrained spread and significant illness, and preparing for future potential challenges presented by the evolving conditions associated with this virus. The plan has 3 core components: It uses metrics that assess risk, which are tied to associated community prevention strategies. It has an early alert signal system that triggers a review of contributing factors and potential changes to community and sector-specific prevention strategies. And it offers a post-surge preparedness plan that is built on our learnings from the past 2 years. Today, I'll share some examples to illustrate how we'll be able to use this plan in the months ahead. First, we can start with our metrics. Throughout the pandemic, decisions regarding our community prevention and mitigation strategies, such as masking or vaccination verification requirements, have been guided by the level of risk that COVID-19 poses to our residents, workers, and healthcare system. Prior to last week, CDC assigned counties a risk level of low, moderate, substantial, or high transmission based on case and test positivity rates, which reflected local transmission levels. Last week, as everyone knows, CDC did release a new methodology for assessing community risk, which we'll be adopting and reporting on weekly. Rather than measure risk based just on transmission rates, the CDC's new risk levels are determined by a combination of the following 3 metrics. New COVID-19 hospital admissions per 100,000 population in the last 7 days, the 7-day average for the percent of staffed inpatient beds occupied by COVID-19 patients, and total new COVID-19 cases per 100,000 population in the past 7 days. Based on these 3 new monitoring metrics, CDC will categorize counties as low, medium, or high community risk level. When determining this community risk level, CDC first determines whether the county had fewer or greater than 200 new cases per 100,000 people in the past 7 days. This then determines the threshold for the hospital indicators, which are then used to determine the community's risk level. Counties with case rates over 200 new cases per 100,000 population in the last 7 days are automatically at either medium or high risk. The hospital indicator thresholds for moving from medium to high risk are set at lower levels once the county passes this case rate threshold. And as you know, last week, CDC assigned us to the high risk category, but I'm pleased to share that as of today, CDC has assigned LA County to the low community risk level based on the following metrics. Our case rate for the past 7 days is below 200 cases per 100,000 population at 111 new cases per 100,000 people. Our 7-day average for the proportion of staffed inpatient beds occupied by COVID-19 patients is at 5.5%, which is in the low range. And our 7-day average for new COVID-19 hospital admissions is 7.4 admissions per 100,000 people. This also meets the CDC criteria for low risk. Since we have moved to this lower level, we'll issue a health officer order today that I'll discuss in a minute, replacing our masking and vaccination verification requirements with strong recommendations. We're also proceeding with a series of community prevention measures that correspond with this risk level. Next slide. The identified community levels risk metric helps us assess not just our current level of risk, but it also allows us to trigger a set of community prevention strategies that correspond with the assigned risk level. Our post-surge response plan includes community prevention strategies in 4 key areas: masking, testing, vaccination verification, and ventilation. Specific strategies will be implemented based on our risk level, with more layers of protection added when we're at a higher risk level. Since we're now in the low community risk level, what you're seeing on here are other community prevention strategies that align with low, and these reflect the reduced risk. And as I noted, some of which are going to require changes to the health officer order. In most public settings, indoor masking requirements will be replaced by a strong recommendation for all individuals, regardless of vaccination status, to wear masks when in indoor public places. All employers will be required to offer, for voluntary use, well-fitting medical-grade masks and respirators to employees working indoors in close contact with other workers, customers, or members of the public at any sites where masking becomes optional. Because masking does remain an important layer of protection, which is why we continue to strongly recommend people keep their masks on when they're indoors. Masking will continue to be required indoors at TK through grade 12 schools as required by the state until March 12th, as well as they will continue to be required indefinitely at healthcare facilities, correctional facilities, public transit, transportation hubs, congregate care facilities, and homeless and emergency shelters, again, as required by state or federal regulations. In addition, masking is still required for individuals who are permitted to end isolation or quarantine early because they tested out through day 10 after their exposure. As a reminder, regardless of the county's risk level, individual businesses can establish their own requirements around masking and other protective measures, and people are free to wear a mask even if it's not required, based on their personal preference, their comfort level, and informed by their personal level of risk or risk to others in their household. Next slide. As you can see, we've also aligned testing and other prevention strategies with our community risk level. At every risk level, testing is required to exit isolation or quarantine between days 6 and 10. And anyone exposed to COVID or has symptoms should also go ahead and get tested. In the low community risk level, vaccination verification is required for entry to indoor mega events and for healthcare workers and employees at healthcare facilities and high-risk congregate settings. Finally, in all risk levels, facilities are expected to ensure and maintain improved ventilation throughout indoor spaces. So as you can see, vaccination verification is only strongly recommended now for entry to outdoor mega events and indoor portions of bars, nightclubs, lounges, wineries, distilleries, and breweries. Next slide. When adjusting our strategies to meet our current risk profile, some changes need to be issued via health officer order. That will be posted later today, and it'll be in effect tomorrow. Under the modified order, indoor masking will be strongly recommended but not required for vaccinated and unvaccinated individuals in public settings and businesses, except in those high-risk settings where federal and state regulations continue to require masking. These settings where masking continues to be required, I'm going to repeat this just because I know it can create some confusion, include public transit, transportation hubs, all healthcare settings, including long-term care and adult and senior care facilities, all emergency shelters, correctional and detention facilities, homeless shelters, and as I said, cooling centers. Masks are also required indoors at schools and childcare facilities until March 12th, when masking will instead be strongly recommended for students, children, teachers, and staff, regardless of vaccination status. School districts in LA County may continue to require masking at schools and during school activities, along with requiring other appropriate safety precautions for their school community. At all sites where masking indoors is no longer mandatory, employers are required to offer, for voluntary use, medical grade masks and respirators to employees who work indoors in close contact with other workers, customers, and/or members of the public. I do want to stress that although masking is not required, both the state and our public health department strongly recommend masking, regardless of vaccination status, in all indoor public spaces, while transmission continues to pose a risk. The health officer order also modifies requirements related to pre-entry vaccination or negative test verifications. As I noted earlier, the health officer order will change to reflect the following. Vaccine verification will still be required in healthcare and congregate care settings. Pre-entry vaccine verification remains required for entry to indoor mega events, with a negative test result as a substitute for those not fully vaccinated. That is per the state order. Pre-entry vaccine verification or verification of a negative COVID-19 viral test is strongly recommended, but no longer required at outdoor mega events and indoor portions of bars, nightclubs, and lounges. Next slide. I have now briefly reviewed the first core component of our post-surge response plan, which is the use of the CDC metrics to assess risk and then implement community prevention strategies that are appropriate for that level of risk. And I touched on various prevention strategies that we'll be using now that we're in the low risk category, some of which, as I noted, will require those changes to the health officer order. The second component of our post-surge response plan is to monitor early alert signals. In addition to using the CDC metrics to assess community levels of risk, we have designated 7 early alert signals that we will monitor locally. These can alert us early to concerning trends that might lead to higher COVID-19 transmission or increased illness severity. These signals include 3 community-wide measures: variants of concern, emergency department COVID-19 visits, and cumulative case rates in our high poverty communities. And as you can see here, for each of those measures, we establish the thresholds for what's of low concern, moderate concern, or high concern. The signals also include 4 sector-specific measures, which are new outbreaks at skilled nursing facilities, new outbreaks at TK through grade 12 schools, new outbreaks at settings with persons experiencing homelessness, and clusters of cases at work sites. If there are alerts in 2 or more sectors which reach the threshold for moderate or high concern, we'll conduct an in-depth review of contributing factors and consider changes to community prevention strategies. Sector-specific alerts that reach the threshold for moderate or high concern will result in mitigation measures that are tailored to that setting. The thresholds for each risk level, as I noted, you can see on the slide. And as you can see, for this week, only 1 indicator reached the threshold for moderate concern, and that was new outbreaks in TK through grade 12 schools, with 7 outbreaks opened in the last 7-day period, February 24th through March 2nd. All of the other alerts are of low concern. Next slide. As noted, the 7 new outbreaks were opened in schools over this last week. And as a result, our school-based team will review possible contributing factors and consider working with school administrators to implement the following enhanced measures to help prevent transmission in schools. We'll be strongly recommending masking indoors for staff and students, obviously still a requirement, but after March 11th, we'll continue to strongly recommend that given this early alert signal. Improving ventilation wherever possible at school sites, monitoring students, teachers, and staff for symptoms. We're recommending weekly testing of unvaccinated individuals and also the continuation of response testing, which is initiated when people present with symptoms or they've had an exposure. We promote the proper isolation of cases and recommend a test to return for those who want to have a shortened isolation period. We're recommending the implementation of weekly testing of unvaccinated individuals in the group when group contact tracing is being used. And finally, as always, all schools are required to report immediately any outbreaks among staff and students to public health. This example illustrates how monitoring for early alert signals will allow us to identify issues that may be cause for concern, quickly assess the situation, and put in place additional sector-specific measures that are intended to help slow the spread and contain, in this case, these outbreaks. Next slide. Our post-surge response plan also includes monitoring for variants of concern. Viruses like SARS-CoV-2 change over time. Sometimes these changes impact the way the virus behaves in people. Some changes can make it easier to pass an infection from one person to another, and some might make the virus cause more severe illness. Sometimes a virus can change in the way that makes it more able to hide from our immune system or withstand the medications used to treat COVID-19. When scientists detect a version of the virus with a change that might cause one of these effects, they're called a variant of concern or of concern. We're going to continue to monitor for the presence of variants in LA County. And if 5% or more of our specimens that are sequenced are identified as variants of concern, a new variant of concern, we'll consider that to be an issue of moderate concern and will again do further investigation. Here we're looking at the current sequencing results. As you can see, the Omicron variant, represented by both blue and red shading, remains our predominant variant, accounting for fully 100% of all cases with sequence specimens collected in the week that ended February 19th. There are no new variants of concern that are circulating currently in LA County. But we're also tracking, as you can see here, the sublineages of Omicron. The BA.1.1 lineage, it's a descendant of the lineage of BA.1, remains the primary Omicron subvariant that's been identified. The sublineage BA.2, which is shown in that tiny sliver of red, has been shown to be, that sublineage has been shown to be 30% more infectious than BA.1. And as you can see here, it's been increasing very slowly in LA County. So it still makes up a very small proportion of all of our sequence cases. For the week ending February 19th, 4% of sequence specimens were BA.2, and to date, a total of 136 BA.2 specimens have been identified. This is a doubling of our total count since last week, when we reported 67 BA.2 cases, and it's consistent with findings that there is starting to be more spread across the United States, and that's going to warrant closer tracking. Next slide. The last core component of our post-surge response plan is a preparedness plan. COVID-19 remains an unpredictable virus, but the lessons we've learned from navigating more than 2 years of the pandemic can and should inform our post-surge preparedness activities. Here in LA County, preparedness activities will be focused in 5 areas that are identified on the slide. For preparedness for outbreak management, our work sites are required to report clusters of 3 or more cases in a 14-day period to public health. And that's part of this broader strategy to ensure workplace safety and protect employees. We're going to continue to work with employers to ensure that they understand how to implement any outbreak mitigation requirements that are passed on to them from the public health department. We'll continue to cross-train public health staff so that during times of increased outbreaks, our ability to investigate and mitigate at work sites is not compromised. Testing has been an essential strategy, and access to free and accessible testing remains important, especially in high-risk settings and in neighborhoods where there are higher case rates. Maintaining a vibrant testing network requires an expansion of opportunities to link testing to existing healthcare sites and to secure supply chains and distribution networks of over-the-counter test kits. These can be used during outbreaks and high-risk settings and in our hard-hit communities. Therapeutics are the new medications that are powerful tools for preventing severe illness among those at high risk. We do remain focused on expanding partnerships with providers and pharmacies so that we can ensure a vast network of providers who can provide both information and testing and prescriptions for the therapeutics. We're going to offer a call. We've stood up a call center for residents where they can get more information, and we'll be piloting telehealth options that increase access in low resource communities. Vaccinations, of course, remains a cornerstone of our efforts. Increasing our vaccination coverage remains a priority. We'll maintain a network of at least 300 mobile teams and 1,000 fixed sites. We plan to expand the number of registered providers and also increase the number of health plans that are providing vaccines to homebound individuals. And capturing the varied information needed to track pandemic progress and challenges through a robust surveillance system remains essential. This now includes ensuring our capacity to sequence between 15 and 25% of positive specimens so that we can monitor potential variants of concern. We need to expand wastewater surveillance so that it's county-wide, increase the capacity for us to use sentinel sites like our emergency departments, and maintain an ability to track vaccination coverage. Next slide. As noted, ensuring equitable access to therapeutics is one of the 5 core areas of our preparedness plan, since these free treatment options can prevent severe illness and hospitalization from COVID-19. As access to effective therapeutics improves, equitable distribution of COVID-19 treatments is a critical issue, and we'll need to ensure that information about and access to these medications are available across the entire county. And with a particular emphasis on making sure there's good access in those communities where residents are at elevated risks of poor COVID-19 outcomes. One of the things we do as part of our preparedness plan is we track the distribution of the three new therapeutic options that have been authorized by the FDA for the treatment of COVID-19 in individuals ages 12 and over who are at higher risk for severe illness. These include 2 oral therapeutics that require a prescription from a healthcare provider and must be taken within 5 days of first having COVID-19 symptoms. This is Paxlovid and Molnupiravir. And then we have Evusheld, which is an injection that can be offered prior to getting infected for individuals who can't get a COVID-19 vaccine for medical reasons or may not respond well to a vaccine because they have a weak immune system due to a medical condition or treatment. The data on this slide are based on a provider survey where providers who are prescribers are asked to report the zip code of the patient who was prescribed these therapeutics. And it represents over 2,000 total doses that were prescribed between the beginning of January and March 1st. This survey obviously doesn't represent all the doses that public health has been able to distribute to providers, nor does it represent all the doses that have been distributed through out of the county providers to residents here in the county. But although this reflects only a sample of the doses distributed, it does give us a sense of the distribution patterns. On this map, the areas with the fewest people who have been prescribed a therapeutic are shaded in the lighter colors, and the areas with more people who have been prescribed a therapeutic are shaded with darker colors. Although there's no way for us to adjust for differences in population sizes or the number of people who are eligible for these therapeutics, it does allow us to take a look and visually see where people are having easier access perhaps to this medication and where in fact there's less prescribing that's going on. As the map shows, you can see there's a lot of variation across the county. Areas with the fewest patients are not clustered in just 1 or 2 areas, but they're spread really throughout parts of South LA, parts of East LA, Malibu and surrounding areas, parts of the San Gabriel, San Fernando, Santa Clarita, and Antelope valleys. Because providers need to be registered in a federal management platform to receive these medications, our biggest effort right now as part of preparedness is to work to enroll more providers so that we have a vast network of sites that can both provide information, prescribe, and have a sufficient supply of therapeutics. As I noted a couple of weeks ago, we still have a lot of scarcity on the availability of these therapeutics, and that translates to only people at very high risk having any access. But part of being prepared is understanding that that situation ought to change in the next month or two. And we do want to build out a vast network that makes it very easy for folks to be able to both get tested quickly, and then because this is a time-limited intervention for 2 of the oral medications, be able to get that prescription and the medication very rapidly. I do want to note that residents who have questions or they want to know about how they can access these medicines should contact their medical provider, or they're welcome to call our information line at 833-540-0473. That's open 7 days a week, 8 in the morning till 8:30 at night. This call center, it's a free resource. Residents can get information that's culturally and linguistically appropriate about available therapeutics and also about how to access them. Next slide. Along with therapeutics, ensuring access to vaccines is a key part of our preparedness efforts. And as the next 2 slides show, the reason for this is because the vaccines remain powerful tools for preventing illness, hospitalizations, and deaths. This first slide shows the 7-day age-adjusted case and hospitalization rates for people 5 years of age and older for the period of February 13th through 19th by vaccination status. Rates for unvaccinated people are shaded in purple. Rates for fully vaccinated but not boosted people are shaded in yellow. And rates for individuals who are fully vaccinated and boosted are shown in blue. While no vaccine is 100% effective, and there's a chance that individuals who've been vaccinated and boosted can become infected. As you can see, being fully vaccinated against COVID-19 means that you have a very good chance at preventing infection and that these vaccines remain extremely effective in preventing hospitalizations. After being fully vaccinated and boosted, you can see here people had much better outcomes. For instance, unvaccinated people were about 4 times more likely to be hospitalized for COVID-19 when compared to those fully vaccinated, not yet boosted, but they're 9 times more likely to be hospitalized than people who were vaccinated and boosted. And as we can see, if you can go to the next slide, the difference is even greater when we look at deaths. Here we compare, we can go to the next slide. Here we compare the 7-day age-adjusted death rate for people 5 years of age and older for the period of February 6th through the 12th by vaccination status. For this time frame, fully vaccinated individuals were 18 times less likely to die from COVID-19 than unvaccinated individuals. We don't have enough people who have been fully vaccinated and boosted to be able to do this calculation separately for that group. So the number of people fully vaccinated includes people who are also fully vaccinated and boosted. Next slide. This data, we continue to show it, uses real-time information from LA County residents, which is why we're constantly trying to make sure people have the information that shows us that the vaccines continue to work to prevent against the worst COVID outcomes. But as I noted, part of preparedness is making sure we can continue to track this, because you would want to get an early alert that the vaccines weren't providing as much protection at some point in the future as they have in the past. But unfortunately, as you can see on this slide, our pace of vaccination has slowed significantly in recent weeks. And while this is to be expected because we have 8 million LA County residents vaccinated, that does leave approximately 1.7 million eligible residents that haven't yet gotten their first dose, as well as about 2.7 million residents who are eligible for it but haven't received an additional or booster dose. In addition, as we've been documenting throughout this past year, there are significant gaps in coverage that based on age, geography, and race and ethnicity. The next couple of slides are going to look at data showing disparities among older adults based on race and ethnicity and place of residence. We can go to the next slide. Given how effective vaccines and particularly boosters are at preventing COVID-related infection, severe illness, and death, it does remain disheartening that not everyone in LA County is benefiting equally from the life-saving power of these vaccines and boosters. In part, as we've noted before, these differences reflect the impact that race and ethnicity and poverty have on levels of exposure and access to health-affirming resources. But in part, they also reflect differences in vaccination coverage. While 99% of adults 65 and older in LA County have received at least 1 dose of the vaccine, booster coverage drops off significantly, and only 63% of adults 65 and older are fully vaccinated and boosted, leaving hundreds of thousands of older adults unnecessarily vulnerable to infection, severe illness, or death. Furthermore, there are significant coverage gaps based on race and ethnicity and place of residence. Overall, as of February 27th, for adults who are 65 and older, 80% of Asian individuals were fully vaccinated with a booster dose, compared to 76% of white residents, 73% of Black African American individuals, and 70% of Latinx individuals in this group. Given that this age group is at elevated risk of severe disease, hospitalizations, and death, closing the gaps in booster coverage does take on some urgency. This slide and the following slide show the gaps, both based on race, but also based on place of residence. Each map shows the proportion of adults 65 and older who were fully vaccinated and had received a booster dose as of February 27th for each of our health districts and for each different racial and ethnic group. Yellow shading denotes health districts with booster coverage that is under 51%. Green denotes coverage from 51 to 54%. Blue denotes coverage from 55 to 62%. And purple shading denotes booster coverage that's greater than 62%. The first map shows the coverage levels for Asian older adults. Because this group has the highest vaccination coverage, it does serve as a comparison group on these slides. The other maps show vaccination coverage by health district for Black, African American, Latinx, and white residents 65 and older. As you can see from these three maps, efforts are needed to improve booster coverage across many parts of the county and among older residents of all races and ethnicities. Booster rates are lagging more significantly among older Black and Brown residents and those living in parts of Central LA, East LA, West LA, the San Fernando Valley, the Harbor area, and Antelope Valley. Next slide. This slide shows shows the vaccination coverage levels for white adults and older compared to Asian adults. Rates for white older adults were lowest in Antelope Valley, but they're also low with less than 55% coverage in the East Valley, Glendale, Hollywood, Wilshire, and Whittier health districts. The findings shown on both of these slides point to the need to seek solutions to complex and longstanding issues that, as we've noted, are contributing to these troubling gaps. I want to note that this is not likely to happen without providing additional resources and protections for those at elevated risk for poor outcomes. And as a reminder, residents who are homebound can request an in-home vaccination visit for no charge. They can visit us at vaccinatelacounty.com, or they can call the call center for more information. I do want to acknowledge and appreciate all of the trusted partners that continue their efforts to increase awareness, answer questions, build vaccine confidence, and link individuals and communities to vaccination sites. These strategies that they're using include door-to-door outreach in low vaccination coverage communities. They're tabling at vaccine clinics and community events. They provide information and vaccine reminders through phone calls and text messaging. And they're using social media platforms that feature local residents. Next slide. Before closing, I do want to provide a brief update regarding a change in the guidance for the timing of the second doses of the mRNA vaccines. This is the Pfizer, BioNTech, and the Moderna vaccines. Previously, CDC recommended receiving the second dose of the Pfizer vaccine 3 weeks after the first dose, and the second dose of the Moderna vaccine 4 weeks after the first dose. CDC recently released updated COVID-19 vaccine guidance that expands the recommended time between the initial 2 vaccine doses for Pfizer and Moderna to 8 weeks for some people over the age of 12. Getting the second dose 8 weeks after the first may be best for most people between the ages of 12 and 64. Especially for males between the ages of 12 and 39. This is because having a longer time between the first and second doses appears to improve the effectiveness of the vaccine, and it lowers the rare risk of myocarditis. Of note, in spacing out the 2 doses, however, that does mean that there's a longer period of time during which a person is at greater risk of being infected before they receive their second dose. Because of this, the shorter interval between the first and second doses of 3 weeks for Pfizer and 4 weeks for Moderna is still recommended for all children under the age of 12, for people who are at risk for severe disease, including adults age 65 and older, and those that are moderately or severely immunocompromised. Others who need rapid protection because there's either high community spread where they live, work, or travel, or because they need to be vaccinated for school, work, or travel, may need to adhere to the shorter time periods between the 2 doses. Please note that the information on this slide reflects the interval for the general population, and as I noted, the recommendations differ for those who are moderately or severely immunocompromised and those who are in the younger age group. And while these are guidelines, individuals may want to consult with their healthcare provider to make the optimal choice for the timing of their second dose based on their specific situation and risks. We have updated all of the COVID vaccine schedules, all of the flyers on our COVID vaccine website, so it does include information regarding these updated intervals for teens, adults, and individuals that are immunocompromised. Go on to the last slide. With fewer people becoming infected and becoming severely ill with COVID-19, and safety requirements being relaxed, it's very tempting to think the pandemic is over and that we can return to the way things were before the pandemic. And while transmission has greatly slowed, and we're in a much better place with our powerful tools that help so many avoid the worst effects of this virus, there do continue to be thousands of people whose lives, families, and work are disrupted each day because either they or someone close to them is newly infected with COVID-19. And for some of these people, their infection can and will lead to more severe illness. Given the unpredictable nature of the SARS-CoV-2 virus and the hundreds of thousands of residents in LA County that continue to be at elevated risk for infection and possibly severe illness, we do strongly encourage everyone to continue to work together to slow transmission, making sensible choices and decisions. All of the community prevention strategies in our post-surge response plan help reduce transmission. However, with a vastly decreased reliance on mitigation requirements as opposed to recommendations, vaccines do take on a more important role in community prevention. This is because vaccines offer a lot of protection both to the vaccinated person and to those who are around the person who's vaccinated. Vaccines are also the safest way to build individual and community immunity without having people getting sick or risking becoming severely ill. While prior infection affords real protection, this protection, as we know, fades with time. And it's safer then to get vaccinated post-infection than to get reinfected. Finally, it's in all of our interests to reduce chances for the virus to mutate. And this is also most easily accomplished when we decrease the number and the spread of infections. So if you're not fully vaccinated or you're missing your booster, even while our case numbers are dropping significantly, this is still a very good time to make that appointment or walk into one of the hundreds of convenient sites across the county where you can get your vaccine or booster for free. We appreciate everyone's effort to keep this positive momentum as we implement this post-surge plan. Thank you, and I'm now honored to introduce the Chair of the Board of Supervisors, Supervisor Mitchell, to share her remarks. I do want to note that, Supervisor Mitchell, I so appreciate your leadership and ongoing guidance. Been superbly helpful as we think about the refining of mitigation strategies as we're working to figure out the best ways to address the inequities and helping to make sure that the county is prepared for potential new variants or future surges. So thank you so much, Supervisor Mitchell.
And as always, thank you, Dr. Ferrer. I appreciate you and your entire team and the fact that you continue to provide us and drill down to local data and how our local county data has really driven our policies, which is what has kept us safe and can be fully credited for our numbers now decreasing. Thank you very much. And so Friday, tomorrow is a big day, thanks to the CDC's new metrics. No longer mandatory, but still recommended. I heard you loud and clear, Dr. Ferrer. You know, the fact that your data continues to remind us that looking at countywide averages is not the only important data point, but to really drill down based on race, ethnicity, and class. And the blaring differences your chart showed us today is really sobering and a reminder to me that as we move back into our new status of low risk, that we're clear at the community level that we can't have a one-size-fits-all approach to ongoing prevention practices. And so again, hoping that people will do what's best for them, their families, and their communities in choosing to continue to mask or not. We need to be conscientious and follow the guidance, really making sure we're prioritizing the needs of the county as a whole with common sense protections that really enable everyone to thrive. Health is really not just the absence of disease, and our county will be healthy and fully recover when every resident has the opportunity to experience true well-being and attain their full health potential. That's why I will continue to support you in making sure that vaccination and testing sites are available, particularly in those hot, if you will, areas you showed us on the maps. And really look forward to continuing updates on the availability and distribution of therapeutics, wanting to make sure that we continue to leverage all of our county partners who are helping us with testing and vaccination to make sure therapeutics are available to all who need them. With that, Dr. Ferrer, I appreciate being included in today's briefing.
Thank you so much, Supervisor. And we'll go ahead and open for questions.
Wonderful. Our first question is going to come from Ryan Carter from LA Daily News. Ryan, you're unmuted.
Hi, thank you. Good afternoon, Dr. Ferrer and Supervisor Mitchell. Thanks for the time today. Really quick, and I think, Doctor, you were sort of tapping into it toward the end of your presentation today, but I guess I was just wondering if we are indeed now in sort of an endemic phase, if we are in that phase now that we're in this sort of low bracket under the federal government standard. Is that kind of a semantic thing that doesn't really matter? Or is there a point when you believe we truly will be in such a phase, such an endemic phase? And then just as a perhaps somewhat more tangential question, curious about universities. I haven't heard much about how this was playing out at some of our big sort of secondary education institutions, and was really curious, like, and I realize everybody has sort of, they can do what they feel is right based on conditions there, but what's your sense there? Do you feel like they will be opening up to sort of loosening up these masking requirements anytime soon? Thank you.
Yeah, thanks so much, Ryan. In terms of the universities, we do have a weekly call with them next week, and always available to help answer questions. But you're absolutely right. There's been a lot of discussion, throughout the whole surge, on what policies and practices work best at which sites. With the exception, as you've noted, about the stringent requirements around masking indoors. And there were also some testing requirements that went along with some of their policies, some of their practices, particularly in, sort of situations where they had outbreaks. We're strongly recommending that people continue to wear a mask indoors for this next while. So, and that's what we'll say when we meet with universities and colleges and the trade schools. It's always a good idea, especially when you're in the transition part of the pandemic, as we are now, to be very deliberate and thoughtful about how you are moving from certain protections that were offered to either not offering those protections or replacing them with different protections. And in places where there are thousands of people that gather every day, being cautious, I think makes a lot of sense. I say the same thing, for all of our wonderful partners at schools. Being cautious makes a lot of sense. Being thoughtful, being responsive, all of that makes a lot of sense, because these are communities where lots and lots of people are interacting every single day. And the decisions, therefore, particularly for those most vulnerable who are, participating in these larger communities, the decisions can have a big impact. So we're going to, again, make ourselves available. We are moving from requirements to strong recommendations, but sometimes I think people here we're moving away from requirements, and that means it's not important to mask. So I don't want to be like the broken record, but it is still important to mask. In many, many settings, it's still going to be important for people to mask. And, our hope is that in many of those settings, people will mask. And again, really important to us that nobody feel ashamed of masking as well. In this time where people in some settings are going to have choice, let's be respectful of each other's choices, and make sure that, some of the shaming that we've seen in some of the protests recently, around school children being shamed because they're wearing their masks, that really is inappropriate, needs to stop. And in terms of your question, it's a super interesting question, Ryan, about sort of endemic. I really avoid that word because I'm not really certain of what we all think when we hear the word endemic. I fear that some people hear endemic and they think nothing to worry about. It's just kind of with us. It's like a common cold. Endemic, malaria is endemic and it's super serious. TB is endemic, also super serious. So, yeah, I think in some ways, I think it may be more helpful to understand that COVID-19 is a deadly virus. It's still with us. It has ebbs and flows, and we need to take advantage of the good times that we're about to, be in, where we really are seeing much less risk across the board for so many, and then be prepared should there be a new variant of concern or we experience another surge. And I hope that when people hear the word endemic, it doesn't mean to them that we don't need to do anything. We don't need to do anything now. We don't need to do anything to stay well prepared, because I don't think either is true. I think there's still some really important efforts, the distribution of therapeutics, the ability to make sure people can still continue to test for the variety of reasons that it makes sure that makes sense to test, and that we maintain this vibrant network of mobile teams that can pop up and do vaccines, that can attend to homebound individuals and individuals in higher risk communities, and that people feel comfortable getting more information. I always say, there are lots of parents who haven't vaccinated younger children yet, and for them there are very good reasons why they're delaying that decision. But during this time, we need to be prepared, as parents may change their mind. As hopefully sometime later in April or May, we're going to open back up for vaccinating our youngest residents. We don't think of endemic being there's not a lot of work left to do. I think from where we're sitting, there's a lot of work, and I'd be negligent not to also mention that wherever there are outbreaks, there's a lot of risk for spread. So everyone is going to need to be patient and flexible, because if you experience an outbreak, our team is going to pay you a visit or have a phone call with you, so that again, we can rapidly do all of the mitigation necessary in those situations to reduce the number of people that will be impacted by those outbreaks. But I appreciate the question. And I don't know, Supervisor, I know everyone has thoughts about, how to think about endemic. I just worry because I think, there's lots of things endemic that are super dangerous.
And I'm glad you gave us those examples of malaria and tuberculosis. And I think, I have heard constituents say, assume that the preface to endemic end means it's over and it's ended. And I've said, yet not. And I think, beyond the masking, where we spent a lot of time talking about it, the other good health habits that we got into in terms of our hand washing and, a kind of a natural tendency towards social distancing. I turned around and I could see my Clorox wipes here in my own screenshot that they're here at my office to, disinfect doorknobs and keyboards. So I think those practices we don't talk much about, but should be good practices to continue indefinitely at this point.
Yeah, that's such a helpful reminder. I want to note that we've had less than 1,000 cases of flu this year. It's like super low from us, and only a very small number of deaths because the cases are so low. And it is because the steps we're taking prevent transmission of lots of respiratory diseases. So again, some of these steps, as you noted, Supervisor, they're helping us be healthier overall as a community as well. We can go on to the next question.
Our next question comes from Margaret Carrero from KNX. Margaret, go ahead.
Dr. Ferrer, thank you so much for taking the questions. A few things I wanted to ask you about briefly here. Those 7 early alert signals that you had brought up, that you're going to be monitoring, the idea of if there are alerts at 2 or more of those, would that mean the potential to look at the masking now being strongly recommended, maybe bringing back the requirements? You spoke a lot about vaccines and how important they are. Where do you stand on a second booster shot? Is it needed at this point? And finally, will LA County be offering a 3rd dose for J&J recipients? I know they've done that in San Francisco, and if so, would it be Pfizer only?
Yeah, those are great questions. Let me start with the 2 about the boosters. So, the second booster dose is not yet recommended or approved by either the FDA or the CDC. For people who are interested in getting that second booster dose, and obviously, people are tracking data, are seeing in some countries they're offering it, particularly for older people. It can be if you go to your physician, your clinician, and they suggest you go ahead and get that second booster dose, then it would be an appropriate decision, because it's a way to use a drug that's been approved in general, but not for a specific reason, not for the specific reason for everybody. But if your provider says, I think this is a good idea for you, then it makes sense to go ahead and do it. So, as the public health department, we are not going to advise people to go get a second booster shot because the FDA and the CDC have not approved that yet. But there are people who may be interested, and those people should talk to their own provider, who can give them the best advice on whether they should get that second booster shot. And we'd say the same thing for the third dose for people who got J&J. We rely very heavily on CDC and FDA to issue the appropriate guidance based on their extensive research and their extensive review about how best to use the vaccines. And while I appreciate that in some settings, again, this may be the best and most sensible path for a particular individual, we urge those individuals to work through a healthcare provider who can help them make that decision. And in terms of the early alerts, we have, as you noted, like we didn't tie the early alerts to, like, if we get 2 or more early alerts, we're going to do A, B, C, and D. The only place that you'll see some action steps recommended are for sector-specific early alerts, and it makes total sense there. If you see a lot of outbreaks in work sites, there are some things you might want to do that are specific to work sites. But in terms of what you're suggesting, something as broad as, returning to a masking requirement, I don't actually see that sort of in the near horizon at all. But again, you use an early alert system so that if you've got these signals and they're really concerning, don't wait until you see something showing up at hospitals. We all know that hospitals are a lagging indicator. And while we want to all do our best to protect our healthcare system, we also want to protect people from unnecessary illness and death. So if we see something super concerning, everything is on the table. And I think that would hold for any place in the whole country that's tracking their information. We wanted to formalize this so that other people can track the same way we do. This will be on our dashboard starting this afternoon so that everyone can see, this is the data we're looking at. These are the places where we think we get some early signals, and we should use those early signals to inform our responses always. But as you saw, 6 out of the 7 signals are of low concern right now, because the thresholds, of course, reflect how much better we're doing as a county than we were doing before.
That concludes our question portion. Any closing remarks, Dr. Ferrer, Supervisor Mitchell?
I'll defer to Supervisor Mitchell.
Thank you, Dr. Ferrer. I just want to, on behalf of the entire board, join with Dr. Ferrer in extending our heartfelt sympathies, not only to every Angelino who's lost a family member, but particularly to the family members of those 10 young people. It's that sense of loss that we've worked very hard to avoid. And so I just wanted to add our voice to extending our sympathy.
Thank you so much, everyone. We'll see you all next week.
Thank you, Dr. Ferrer.
Thank you, Supervisor Mitchell.
Thank you for joining us today. Additional media questions can be sent to our media inbox at media@ph.lacounty.gov. If you stick around, we have our Spanish remarks in just a few minutes. Hi, Monica, are you there?
Yes, I'm here. Can you hear me?
I can hear you.
Okay.
There you are. Excellent. Are you okay if we get started?
Yes, of course.
Wonderful. Good afternoon, everyone. Thank you so much for joining us for the Spanish portion of today's media briefing. Today is March 3rd, and we have Monica presenting. Monica, when you are ready.
Yes, I'm ready. So, thank you, Kim. Muy buenas tardes, bienvenidos y bienvenidas a la sesión informativa de hoy, donde compartiremos nuestra última actualización del estado de COVID y nuestro plan de respuesta posterior al oleaje de casos. Específicamente, compartiremos nuestros números actuales sobre casos, hospitalizaciones y muertes. Los guiaremos a través de los componentes centrales de nuestro plan posterior a la oleada para el condado de Los Ángeles y presentaremos nuestro primer resumen de las cifras en el nivel comunitario. Compartiremos los cambios en la orden de nuestro oficial de salud y los requisitos actuales para el uso de mascarillas en las escuelas. Hablaremos sobre las señales de alerta temprana del condado y compartiremos las acciones que podemos tomar cuando identificamos algo de qué preocuparnos y discutiremos los componentes de nuestros esfuerzos para estar preparados. Finalmente, cerraremos con un recordatorio de por qué sigue siendo importante para nosotros reducir el COVID-19 en el condado de Los Ángeles. First slide, please. Estamos a varias semanas de ver el final de nuestro devastador aumento invernal y nos complace compartir que nuestra situación y muchas de las cifras han seguido mejorando. Si bien aún no hemos actualizado nuestros niveles previos, nuestros niveles previos al oleaje de casos, estamos por buen camino. A medida que los números continúen mejorando, seguiremos poniendo en práctica cambios sensatos a nuestras estrategias de mitigación, guiados por el plan posterior al pico del condado que está anclado en el marco COVID-19 actualizado tanto del estado como de los CDC. El trabajo continuará hacia reducir el riesgo del COVID-19 para todos los residentes y acortar las brechas que alejan a algunas comunidades y residentes significativamente más vulnerables a los efectos dañinos del COVID. Dado que el virus es impredecible, también nos estamos preparando de modo que estemos listos para adaptarnos rápidamente y tener las opciones de respuesta en caso de una nueva variante, un aumento repentino o cualquier otro desafío que surja. Vamos a ver las cifras. Antes de discutir nuestro plan posterior al aumento, comenzaremos con un vistazo a nuestras cifras habituales de la última semana. Si bien COVID aún representa un riesgo para muchos en todo el condado, nuestros números han mejorado mucho. Durante la última semana, los casos y la tasa de positividad a las pruebas han vuelto a disminuir. Hoy estamos reportando 1,605 nuevos casos. El número promedio de casos nuevos diarios informados los últimos 7 días ha disminuido a un promedio de 1,700 de aproximadamente 2,400 casos durante los 7 días anteriores. Nuestra tasa de casos diario promedio de 7 días ha disminuido a 17 casos por cada 100,000 habitantes. Nuestra tasa de positividad con base en la prueba diaria promedio de 7 días ha disminuido a 1,2%, lo que significa que 1 de cada 80 resultados de la prueba que nos informaron fue positivo en comparación con aproximadamente 1 de 4 a principio del año. Nuestras hospitalizaciones, que como verás son un componente clave de la medida de riesgo comunitario de los CDC, han seguido disminuyendo y hoy informamos cerca de 300 hospitalizaciones menos que el jueves pasado, con 852 personas actualmente con COVID en las clínicas. También nos entristece compartir que esta semana se reportó la muerte de un adolescente, lo que eleva a 10 el número total de muerte entre los menores de edad. Esta, como todas las muertes relacionadas con COVID-19, es una pérdida trágica que tiene un profundo impacto en la familia y los amigos de ese menor. Enviamos deseos de paz y consuelo a los seres queridos y a todos los demás que están de duelo por la pérdida de uno de sus familiares debido al COVID-19. Next slide, please. Como se mencionó, hoy les explicaremos nuestro plan de respuesta posterior a la oleada invernal aquí en el condado de Los Ángeles y explicaremos lo que se ha publicado. Todo está publicado en nuestro sitio de internet. El plan, en este plan se encuentran un conjunto de acciones para garantizar la equidad al proteger a los más vulnerables, incluidos aquellos con riesgo de experimentar tasas elevadas de enfermedad y muerte por COVID-19. Proteger los hospitales y el funcionamiento del sistema de salud. Prevenir la propagación sin restricciones y afecciones negativas y prepararse para futuros desafíos potenciales dadas las condiciones cambiantes del virus. El plan tiene 3 componentes principales. Uso de información para evaluar el riesgo junto con estrategias asociadas de prevención comunitaria, señales de alerta temprana que desencadenan una revisión de los factores que contribuyen a los posibles cambios en las estrategias de prevención específicas en la comunidad y el sector. Un plan de preparación posterior a la oleada que se basa en lo que hemos aprendido en los últimos 2 años. Hoy compartiremos algunos ejemplos para ilustrar cómo podremos usar este plan en los próximos meses. Primero, comencemos con nuestros números. A lo largo de la pandemia, las decisiones con respecto a nuestras estrategias comunitarias de prevención y mitigación, como los requisitos de comprobar el estado de vacunación o el uso de mascarillas, se han guiado por el nivel de riesgo que representa el COVID-19 para nuestros residentes, trabajadores y sistemas de atención médica. Antes de la semana pasada, los CDC asignaron a los condados un nivel de riesgo de contagio bajo, moderado o alto según la tasa de positividad de casos y pruebas, que reflejó los niveles de transmisión local. La semana pasada, los CDC publicaron una nueva metodología para evaluar el riesgo de la comunidad que adoptaremos e informaremos cada semana. En lugar de medir el riesgo en función de las tasas de contagio, los 9 niveles de riesgo de los CDC están determinados por una combinación de las siguientes 3 situaciones. Nuevos ingresos hospitalarios por COVID por cada 100,000 habitantes en los últimos 7 días. El promedio de 7 días para el porcentaje de camas ocupadas por pacientes con COVID que cuentan con la atención de personal. Y un total de casos nuevos de COVID por cada 100,000 habitantes en los últimos 7 días. Con base en estos 3 nuevos criterios de monitoreo, los CDC clasificarán a los condados en el nivel de riesgo comunitario, medio o alto. Al determinar este nivel de peligro en la comunidad, los CDC primero determinan si el condado tuvo menos o más de 200 casos nuevos por cada 100,000 personas en los últimos 7 días. Esto determinará el umbral para los indicadores de hospitalizaciones que luego se utilizará para determinar el nivel de riesgo de la comunidad. Los condados con índice de casos de más de 200 casos nuevos por 100,000 habitantes en los últimos días están automáticamente en la categoría de riesgo medio o alto. El indicador hospitalario para pasar de riesgo medio a alto también se establece en niveles más bajos una vez que un condado supera este umbral de tasa de casos. Nos complace compartir que a partir de hoy, los CDC han asignado al condado de Los Ángeles el nivel de riesgo comunitario bajo, según las siguientes medidas. Nuestra tasa de casos durante los últimos 7 días está por debajo de 200 casos por 100,000 habitantes en 111 casos por 100,000 habitantes. Nuestro promedio diario nuestro promedio es 7 días para la proporción de camas que cuentan en los hospitales con personal para atenderlas y cuyos pacientes están enfermos con COVID es del 5,5% que se encuentran en el rango bajo. Y nuestra tasa promedio es 7 días para nuevas admisiones hospitalarias por COVID es 7,7 admisiones por 100,000 habitantes, que también cumple con los criterios de los CDC para bajo riesgo. Dado que hemos avanzado hacia este nivel inferior, emitiremos una orden del oficial de salud hoy, que explicaremos en breve, que reemplazará nuestros requisitos de comprobar la vacunación y el uso de mascarilla, pero que es altamente recomendable. También estamos procediendo con una serie de medidas de prevención comunitaria para que estén conformes con este nivel de riesgo. Next slide, please. Identificar medidas de los niveles en la comunidad ayudarán a evaluar nuestro riesgo actual y desencadenarán un conjunto de estrategias de prevención comunitaria que correspondan con ese nivel de riesgo. Nuestro plan de respuesta posterior al oleaje incluye esfuerzos de mitigación en 4 áreas claves: uso de mascarilla, pruebas, comprobar el estado de vacunación y promover una mejor ventilación. Se implementarán estrategias específicas en función de nuestro nivel de riesgo con capas de protección que se agregarán cuando estemos en un nivel de riesgo más alto. Dado que ahora estamos en el nivel de riesgo comunitario bajo, se necesitan hacer cambios apropiados para reflejar este número reducido, algunos de los cuales se requieren los cambios de la orden del oficial de salud. Se sigue requiriendo el uso de cubrebocas en el interior de las escuelas de transición al grado 12, según lo exige el Estado, hasta el 12 de marzo, así como de manera indefinida en los centros de atención médica, correccionales, el transporte público, terminales de transporte, centros de atención colectiva y refugios de emergencia y albergues para personas sin hogar, según requerido por las autoridades estatales y federales. Además, aún se requiere que las personas finalicen el aislamiento y la cuarentena, que finalicen el aislamiento y la cuarentena antes de lo previsto y que se hayan hecho la prueba, que usen las mascarillas. Todos los demás requisitos de uso de cubrebocas han sido reemplazados por la alta recomendación y seguimos sugiriendo que todas las personas usen mascarillas independiente del estado de vacunación en espacios interiores. Se requerirá que todos los empleadores ofrezcan para uso voluntario mascarillas regulares o de grado médico que se ajusten bien a los empleados que trabajen en interiores y que estén en contacto con otros trabajadores o clientes en cualquiera de los lugares en donde las mascarillas sean opcionales. Como recordatorio, independiente del nivel de riesgo en el condado, las personas pueden usar mascarilla incluso si no es obligatorio, según su preferencia personal, nivel de comodidad, y teniendo en cuenta su nivel de riesgo o el peligro que representen para otros en su hogar. Slide number 4, please. Como puede ver, también hemos alineado las pruebas y otras estrategias de prevención con el nivel de riesgo de nuestra comunidad. En todos los niveles de riesgo se requieren pruebas para salir del aislamiento o la cuarentena entre los días 6 y 10 y cualquier persona expuesta a COVID o que sea sintomática debe hacerse la prueba. En el nivel de riesgo comunitario bajo, se requiere comprobar el estado de vacunación para ingresar a megaeventos en interiores y para trabajadores y empleados de la atención médica y entornos congregados de alto riesgo. Por último, en todos los niveles de riesgo se espera que las instalaciones aseguren y mantengan una mejor ventilación en todos los espacios interiores. Next slide, please. Al ajustar nuestras estrategias para cumplir con nuestro perfil de riesgo actual, será necesario emitir algunos cambios a la orden del oficial de salud que se publicarán más tarde hoy y entrarán en vigor mañana. Según la reglamentación modificada, será altamente recomendable, pero no se exigirá el uso de mascarillas en interiores para personas vacunadas y no vacunadas en lugares públicos y negocios, excepto en lugares de mucho riesgo, donde las normas federales y estatales continúan exigiendo el uso de mascarillas. Estos entornos donde se sigue requiriendo el uso de mascarillas incluyen el transporte público, terminales de transporte, todos los lugares de atención médica, incluidos los servicios médicos a largo plazo y de adultos y personas mayores, todos los refugios de emergencia, las correccionales, albergues para personas sin hogar y refugios y otros refugios. También se requieren mascarillas en el interior de las escuelas y guarderías hasta el 12 de marzo, cuando será altamente recomendable que los estudiantes, maestros y personal usen mascarilla independiente del estado de vacunación. Los distritos escolares del Condado de Los Ángeles pueden seguir exigiendo el uso de mascarillas o cubrebocas en las escuelas y durante las actividades escolares, junto con otras protecciones de seguridad adecuadas para su comunidad. En todos los sitios donde ya no será obligatorio el uso de cubrebocas en interiores, los empleadores deberán ofrecer para uso voluntario tapabocas regulares o de grado médico a los empleados que trabajen en interiores y que estén en contacto cercano con otros trabajadores y con clientes. Queremos dejar en claro que aunque no se requiere el uso de mascarilla, tanto el Estado como nuestro Departamento de Salud Pública recomiendan el uso de cubrebocas independiente del estado de vacunación en espacios públicos cerrados mientras la transmisión comunitaria siga representando un riesgo. La orden del oficial de salud también modifica los requisitos relacionados con la vacunación previa a la entrada o la verificación de pruebas negativas. Todavía se requiere comprobar el estado de vacunación en entornos de atención médica y de atención colectiva. A la entrada de los megaeventos bajo techo también se debe comprobar el estado de vacunación y las personas no vacunadas deberán presentar el resultado negativo de la prueba. Ya no es obligatorio, aunque es altamente recomendable, comprobar el estado de vacunación y presentar una prueba con resultado negativo en megaeventos al aire libre y en el interior de bares, clubes nocturnos, discotecas. Next slide, please. Revisaremos brevemente el primer componente central de nuestro plan de respuesta posterior a la oleada, que es el uso de las medidas de los CDC para evaluar el riesgo y luego implementar estrategias de prevención comunitaria que sean apropiadas para ese nivel de riesgo. Y mencionaremos varias estrategias de prevención que usaremos ahora que estamos en la categoría de bajo riesgo, algunas de las cuales requieren cambios en nuestra orden del oficial de salud. El segundo componente de nuestro plan de respuesta posterior a la oleada será monitorear las señales de alerta temprana. Además de utilizar las medidas de los CDC para evaluar los niveles de riesgo de la comunidad, hemos designado 7 señales de alerta temprana que monitorearemos localmente. Estos pueden avisarnos temprano sobre tendencias preocupantes que podrían conducir a una mayor transmisión de COVID-19 o una mayor gravedad de la enfermedad. Estas señales incluyen 3 medidas comunitarias: variantes de preocupación, visitas al Departamento de Emergencias por COVID-19 y tasa bruta acumulada de casos en comunidades de alta pobreza. Las señales también incluyen 4 medidas específicas por sector, que son nuevos brotes en centros de enfermería especializada, en escuelas de transición a grado 12, en entornos de personas sin hogar y en lugares de trabajo. Si hay alertas de 2 o más sectores que alcanzan el umbral de preocupación moderada o alta, realizaremos una revisión profunda de los factores que contribuyen y consideraremos cambios en las estrategias de prevención de la comunidad. Las alertas específicas del sector que alcanzan el umbral de preocupación moderada o alta darán como resultado medidas de mitigación que se adaptarán a ese entorno. Los umbrales para cada nivel de riesgo se enumeran en la diapositiva. Como puede ver, para esta semana, solo un indicador alcanzó el tope de preocupación moderada. Nuevos brotes en escuelas de transición a grado 12, con 7 brotes que se abrieron o desencadenaron en el periodo de 7 días del 3 de febrero al 1 de marzo. Todos los demás fueron de baja preocupación. Next slide, please. Como se señaló, se desencadenaron 7 nuevos brotes en las escuelas durante el periodo de una semana, lo cual causa una preocupación moderada. Como resultado, nuestro equipo escolar revisará los posibles factores que contribuyeron y considerará trabajar con los administradores escolares para implementar las siguientes medidas para ayudar a prevenir el contagio en las escuelas. Primero es recomendar que el personal y los estudiantes se cubran la nariz y la boca cuando estén en zonas o en lugares interiores. Mejorar la ventilación donde sea posible. Supervisar a los estudiantes, maestros y personal para detectar síntomas. Hacer pruebas semanales recomendadas para las personas no vacunadas y conducir pruebas de respuesta que se inician cuando se identifican síntomas o la persona ha estado expuesta. Promover el aislamiento adecuado de los casos y recomendar hacerse pruebas tras el regreso de aquellos con periodos de aislamiento más cortos. Implementar pruebas semanales en personas no vacunadas en el brote cuando se utiliza el rastreo de contagios grupales. Y finalmente, informar a salud pública todos los brotes entre el personal y los estudiantes. Este ejemplo ilustra cómo el monitoreo de señales de alerta temprana nos permitirá identificar problemas que pueden ser motivo de preocupación, evaluar rápidamente la situación e implementar medidas adicionales específicas para el sector que pretenden frenar la propagación y contener los brotes. Next slide, please. Nuestro plan de respuesta posterior al pico de casos también incluye el monitoreo de variantes de preocupación. Los virus como el SARS-CoV-2 cambian con el tiempo. A veces estos cambios afectan la forma en que el virus se comporta en las personas. Algunos de estos pueden facilitar la transmisión de una infección entre las personas y algunos pueden hacer que el virus cause una enfermedad más grave. A veces el virus puede cambiar de una manera que lo hace más capaz de esconderse de nuestro sistema inmune o resistir los medicamentos o ofrecer resistencia a los medicamentos utilizados para tratar el COVID. Cuando los científicos detectan una versión del virus con un cambio que podría causar uno de esos efectos, se le llama variante de interés o de preocupación. Continuaremos vigilando la presencia de variantes en el condado de Los Ángeles y si el 5% o más de los especímenes secuenciados se identifican como variantes de preocupación, consideraremos que es un problema de interés y de preocupación moderada e investigaremos más a fondo. Aquí estamos viendo nuestros resultados de secuencias actuales. Como puede ver, la variante Omicron, representada por el sombreado azul y rojo, sigue siendo nuestra variante predominante y representa el 100% de todos los casos con especímenes secuenciados recolectados en la semana que terminó el 19 de febrero. No hay nuevas variantes de preocupación que estén circulando actualmente en el condado de Los Ángeles. También estamos rastreando sublinajes de Omicron. El linaje BA.1.1, un linaje descendiente del BA.1, sigue siendo la principal subvariante de Omicron identificada. El sublinaje BA.2, que ha demostrado ser un 30% más infeccioso que el BA.1, mostrado aquí en rojo, ha ido aumentando lentamente en el condado de Los Ángeles, pero aún representa una proporción muy pequeña de todos los casos secuenciados. Para la semana que finalizó el 19 de febrero, el 4% de las muestras secuenciadas fueron BA.2. Esta duplicación de nuestros recuentos totales desde la semana pasada, cuando informamos 67 casos de BA.2, es consistente con los hallazgos de que está comenzando a haber más propagación en los Estados Unidos, las órdenes de seguimiento de cerca. Next slide, please. El último componente central de nuestro plan de respuesta posterior a la oleada es un plan de preparación. COVID-19 sigue siendo un virus impredecible, pero la lección que hemos aprendido de navegar más de 2 años en la pandemia puede informar nuestras actividades para estar listos para el periodo después del pico. Estas actividades se centrarán en 5 áreas identificadas en esta diapositiva. La primera es preparación para el manejo de brotes. Los lugares de trabajo deben informar a salud pública brotes de 3 o más casos dentro de los 14 días como parte de una estrategia más amplia para garantizar la seguridad en el lugar de trabajo y proteger a los empleados. Y continuaremos trabajando con los empleadores para garantizar que implementen requisitos para la mitigación de los brotes. Continuaremos capacitando al personal de salud pública para que durante los tiempos de aumento de brotes, nuestra capacidad de investigar y minimizar no sea comprometida. Ahora hablaremos de las pruebas. Estas han sido una estrategia esencial y el acceso a pruebas gratuitas y accesibles seguirá siendo importante, especialmente en entornos de alto riesgo y en vecindarios con altas tasas de casos. Mantener una red de muchos sitios que hacen la prueba requiere que los sitios de atención médica existentes hagan la prueba y asegurar las cadenas de suministro y las redes de distribución de los juegos de prueba de venta libre que se pueden usar durante los brotes, así como los entornos de alto riesgo y en comunidades muy afectadas. Tratamientos. Estos nuevos medicamentos son herramientas poderosas para prevenir enfermedades graves entre las personas con alto riesgo. Seguimos enfocados en expandir las alianzas con proveedores y farmacias para garantizar una amplia red de proveedores que puedan brindar información y formular medicamentos. Tendremos un centro de llamadas para que los residentes obtengan más información y probaremos opciones de telesalud para aumentar el acceso en comunidades de bajos recursos. Ahora hablaremos de las vacunas. Aumentar nuestra cobertura de vacunación sigue siendo una prioridad. Mantendremos una red de 300 equipos móviles y 1,000 sitios fijos. Ampliaremos la cantidad de proveedores registrados y aumentaremos o incrementaremos el número de planes de salud que brindan vacunas a personas confinadas en sus hogares. También hablaremos aquí de la vigilancia, que es esencial para capturar la variada información necesaria para seguir avanzando y enfrentar los desafíos de esta pandemia. Esto incluye asegurar nuestra capacidad para secuenciar del 15 al 25% de las muestras positivas con el fin de vigilar posibles variantes de preocupación, expandir la vigilancia de aguas residuales en todo el condado, aumentar la capacidad de usar sitios centinela y mantener la capacidad de hacerle frente a la cobertura de vacunación. Next slide, please. Como se señaló, garantizar el acceso equitativo a los tratamientos es una de las 5 áreas centrales de nuestro plan de preparación, ya que estas opciones de medicamentos gratuitos pueden prevenir enfermedades graves y hospitalizaciones por COVID-19 a medida que mejora el acceso a terapias efectivas. La distribución equitativa de los tratamientos de COVID es un tema crítico y debemos asegurarnos de que la información y el acceso a ellos estén disponibles en todo el condado, particularmente en aquellas comunidades con residentes con un riesgo elevado de resultados graves de COVID. Esta diapositiva muestra la distribución de 3 opciones terapéuticas que han sido autorizadas por la FDA para el tratamiento de COVID en personas de 12 años o más que tienen un mayor riesgo de enfermedad grave por COVID. Primero, 2 tratamientos orales que requieren una receta de un proveedor de atención médica y debe tomarse dentro de los 5 días posteriores a los primeros síntomas de COVID-19. Estas son Paxlovid y Molnupiravir. En segundo lugar está Evusheld, que es una inyección que se ofrece antes de infectarse para personas que no pueden vacunarse contra el COVID por razones médicas o que pueda que no respondan bien a la vacuna porque tienen un sistema inmunitario débil debido a una afección médica o un tratamiento debilitante. Los datos de esta diapositiva se basan en una secuencia de proveedores en la que se les pidió que informaran el código postal del paciente al que se le recetaron estos tratamientos y refleja un total de 2.172 dosis prescritas entre el 29 de diciembre de 2021 y el 1 de marzo de 2022. Los datos de esta encuesta no representan todas las dosis que Salud Pública ha distribuido a los proveedores. Aunque esto refleja solo una muestra de las dosis distribuidas, nos da una idea de los patrones de distribución. En el mapa, las áreas con la menor cantidad de personas a las que se les ha recetado un tratamiento están sombreadas con colores más claros y las áreas con más personas a las que se les ha dado una fórmula para este tratamiento están sombreadas con colores más oscuros. Aunque no se ajusta a las diferencias en el tamaño de la población o la cantidad de personas que reúnen los requisitos para recibir estos tratamientos, el mapa nos da una idea de la distribución en todo el condado. Como muestra esta imagen, hay bastante variación en todo el condado. Las áreas con la menor cantidad de pacientes no se agrupan en una o 2 áreas, sino que se distribuyen por todo el condado, incluidas algunas partes del sur de Los Ángeles o el este de Los Ángeles, Malibú y sus alrededores y partes de los valles de San Gabriel, San Fernando, Santa Clarita y Antílope. Debido a que los proveedores deben estar registrados en una plataforma de administración federal para recibir estos medicamentos, Salud Pública está trabajando para inscribirlos, para garantizar una amplia red de sitios que puedan brindar información y tengan un suministro suficiente de tratamientos. Los residentes que deseen acceder a estos medicamentos o tengan preguntas sobre qué tratamiento es adecuado para ellos deben comunicarse con su proveedor médico o llamar a la línea de información de COVID-19 al 833-540-0473 de las 8 de la mañana a las 8 de la noche todos los días. El centro de llamadas es un recurso gratuito donde los residentes pueden obtener información cultural y lingüísticamente apropiada sobre las terapias disponibles y cómo acceder a ellas. Next slide, please. Junto con los tratamientos, asegurar el acceso a las vacunas es una parte clave de los esfuerzos de preparación. Como muestran las siguientes dos diapositivas, nuestras vacunas siguen siendo una herramienta poderosa para prevenir enfermedades, hospitalizaciones y muertes. Esta primera diapositiva muestra las tasas de casos y hospitalizaciones ajustadas por edad de 7 días para personas de 5 años y mayores para el periodo del 13 al 19 de febrero por estado de vacunación. Las tasas para personas no vacunadas están sombreadas en púrpura. Las tasas para las personas completamente vacunadas, pero sin refuerzo, están sombreadas en amarillo, y las tasas para personas que están completamente vacunadas y con refuerzos se muestran en azul. Si bien ninguna vacuna es 100% efectiva y existe la posibilidad de que las personas que han sido vacunadas se infecten, como puede ver, estar completamente vacunados contra el COVID es muy bueno para prevenir infecciones y extremadamente efectivo para prevenir hospitalizaciones. Y estar completamente vacunado y reforzado produce resultados sustancialmente mejores. Por ejemplo, las personas no vacunadas tenían aproximadamente 4 veces más probabilidades de ser hospitalizadas por COVID en comparación con las que estaban completamente vacunadas pero sin refuerzo, y 9 veces más probabilidades de ser hospitalizadas que las personas vacunadas y reforzadas. Como vemos en la siguiente diapositiva, la diferencia es aún mayor cuando se analizan las muertes. Next slide, please. Aquí comparamos la tasa de mortalidad ajustada por edad de 7 días para personas de 5 años y mayores para el periodo del 6 al 12 de febrero por estado de vacunación. Durante este periodo, las personas con todas las vacunas tenían 18 veces menos probabilidades de morir por COVID que las personas no vacunadas. Next slide, please. Estos datos continúan mostrando a través de información en tiempo real que las vacunas funcionan para prevenir los peores resultados del COVID. Sin embargo, nuestro ritmo de vacunación se ha desacelerado significativamente en las últimas semanas, y si bien esto es de esperar, dado que 8 millones de residentes del condado de Los Ángeles han sido vacunados, todavía aproximadamente 1,7 millones de residentes que reúnen los requisitos para recibir la vacuna, pero que aún no han recibido su primera dosis, así como aproximadamente 2,7 millones de residentes que reúnen las condiciones, pero no han recibido una dosis adicional o de refuerzo. Además, existen brechas significativas en la cobertura. A continuación, analizaremos los datos que muestran las disparidades entre los adultos mayores según la raza y el origen étnico. Aquí vemos que a partir del 27 de febrero, solo el 28% de los niños de 5 a 11 años estaban completamente vacunados, y que las dosis de refuerzo están rezagadas, con solo 41% de los residentes de 12 años y mayores completamente vacunados y con refuerzo. Next slide, please. Dada la eficacia de las vacunas y en particular de los refuerzos para prevenir infecciones, enfermedades graves y muertes relacionadas por COVID, sigue siendo desalentador que no todos en el condado se beneficien por igual del poder salvador de estas vacunas y los refuerzos. En parte, estas diferencias reflejan el impacto de la raza y la etnia y la pobreza que tienen en los niveles de exposición y acceso a recursos que respaldan la salud, y en parte también son un reflejo de las diferencias en la cobertura de vacunación. Si bien el 99% de los adultos mayores de 65 años han recibido al menos una dosis de la vacuna, la cobertura de refuerzo disminuye significativamente y solo el 63% de los adultos mayores de 65 años están completamente vacunados y reforzados, lo que deja a cientos de miles de adultos mayores innecesariamente vulnerables a infecciones, enfermedades graves o la muerte. Además, existen brechas significativas en la cobertura según la raza y etnia y el lugar de residencia en general. A partir del 27 de febrero, al observar los datos de los adultos mayores de 65 años, hemos visto que el 80% de las personas asiáticas se vacunaron por completo y recibieron una dosis de refuerzo en comparación con el 76% de las personas blancas, el 73% de las personas de color y el 70% de las personas latinas en este grupo de edad. Dado que este grupo tiene un riesgo elevado de enfermedad grave, hospitalizaciones y muerte, cerrar las brechas en la cobertura del refuerzo adquiere cierta urgencia. Esta diapositiva y la siguiente muestran las brechas en la cobertura de la enfermedad para adultos de 65 años y mayores según el lugar de residencia y la raza y origen étnico. Cada mapa muestra la proporción de adultos de 65 años y mayores que estaban completamente vacunados y habían recibido una dosis de refuerzo al 27 de febrero para cada uno de nuestros distritos de salud para un grupo racial étnico diferente. El sombreado amarillo denota distritos de salud con cobertura de refuerzo inferior al 51%. El verde indica una cobertura del 51 al 54%. El azul indica que hay una cobertura del 50 al 62% y el morado indica que esta cobertura de refuerzo es superior al 62%. El primer mapa muestra los niveles de cobertura entre los adultos mayores asiáticos. Debido a que este grupo tuvo la mayor cobertura de vacunación, sirve como base de comparación en estas diapositivas. Los otros mapas muestran la cobertura de vacunación por distrito de salud para adultos de color, latinos y blancos mayores de 65 años. Como puede ver, estos tres mapas se necesitan refuerzos para mejorar la cobertura. Se necesitan esfuerzos para mejorar la cobertura de refuerzo en muchas partes del condado y entre los residentes mayores de todas las razas y etnias. Las tasas de refuerzo están rezagadas de manera más significativa entre los residentes de color mayores y aquellos que viven en partes del centro, este y oeste de Los Ángeles, el Valle de San Fernando y el área portuaria y el Valle de Antílope. Next slide, please. Esta diapositiva muestra los niveles de cobertura de vacunación para adultos blancos de 65 años o más por distrito de salud en comparación con las tasas de adultos asiáticos en esta misma edad que se muestra nuevamente en el primer mapa, ya que este grupo tuvo las tasas más altas. Las tasas para los adultos mayores blancos fueron más bajas en el Valle de Antílope, pero también fueron bajas con menos del 55% de cobertura en los distritos de salud del Valle Este, Glendale, Hollywood, Wilshire y Whittier. Los hallazgos que se muestran en ambas diapositivas apuntan a la necesidad de buscar soluciones a los problemas complejos y de larga data que contribuyen a estas brechas preocupantes. Es poco probable que esto suceda sin proporcionar recursos adicionales y protección para quienes tienen un riesgo elevado de resultados deficientes. Como recordatorio, los residentes que están confinados en sus hogares pueden solicitar una visita para recibir la vacuna en su casa que se brinda sin caso si califican para este servicio. Las partes interesadas pueden llamar al centro de llamadas o visitar Vacúnate Los Ángeles para obtener la información. Agradecemos a todos los aliados en los que confiamos, que continúan sus esfuerzos para aumentar la conciencia, responder preguntas, generar confianza en las vacunas y vincular a las personas con los sitios de vacunación en las comunidades más afectadas. Sus estrategias incluyen el alcance puerta a puerta en comunidades con baja cobertura de vacunación, presentaciones en clínica en puestos de vacunación y eventos comunitarios, proporcionan información y recordatorios de la vacuna a través de llamadas telefónicas y mensajes de texto y también publicación en las redes sociales con los residentes locales. Next slide, please. Antes de cerrar, tenemos una breve actualización sobre el cambio en la guía para el momento de las segundas dosis de las vacunas ARNM, que son la vacuna Pfizer, BioNTech y Moderna. Anteriormente, los CDC recomendaban recibir la segunda dosis de la vacuna Pfizer, BioNTech 3 semanas después de la primera dosis y la segunda dosis de la vacuna Moderna 4 semanas después de la primera dosis. Los CDC publicaron recientemente una guía actualizada de vacunas contra el COVID que amplía el tiempo recomendado entre las dosis iniciales de las vacunas de Pfizer y Moderna a 8 semanas para algunas personas mayores de 12 años. Recibir la segunda dosis 8 semanas después de la primera puede ser mejor para la mayoría de las personas entre 12 y 64 años, especialmente para los de 12 a 39 años. Esto se debe a que pasar más tiempo entre la primera y la segunda dosis parece mejorar la eficacia de la vacuna y reducir el raro riesgo de miocarditis. Cabe señalar que espaciar las dosis, sin embargo, significa que hay un periodo de tiempo más largo durante el cual una persona corre un mayor riesgo de infectarse antes de recibir la segunda dosis. Debido a esto, todavía se recomienda el intervalo más corto entre la primera y la segunda dosis de 3 semanas para Pfizer y 4 semanas para Moderna, para los niños de 11 años y menores. Personas con riesgo de enfermedad grave, incluidos adultos de 65 años o más y personas con un sistema inmune deprimido de manera grave o de manera moderada. Otros que necesitan protección rápida porque hay una alta propagación comunitaria donde viven o trabajan o viajan o porque necesitan vacunarse para ir a la escuela, trabajar o viajar. Tenga en cuenta, la información de la diapositiva refleja el intervalo para la población general. Y como se señaló, las recomendaciones difieren para aquellos que están moderada o gravemente con el sistema inmune comprometido. Y si bien estas son pautas, es posible que las personas deseen consultar a su médico para tomar la decisión óptima sobre el momento de su segunda dosis en función de su situación y sus riesgos específicos. Hemos actualizado nuestros folletos del programa de vacunas contra el COVID en nuestro sitio de internet para incluir información sobre estos intervalos. Esta información es actualizada tanto para los adultos como para los adolescentes y para las personas que tienen el sistema inmune comprometido. Next slide, please. Con menos personas que se infectan y se enferman gravemente con COVID y los requisitos de seguridad se relajan, es muy tentador pensar que la pandemia ha terminado y que podemos volver a ser como eran las cosas antes de la pandemia. Y aunque el contagio se ha disminuido considerablemente y contamos con herramientas poderosas que ayudan a muchos a evitar los peores resultados o efectos de este virus, sigue habiendo miles de personas cuyas vidas, familias y trabajos se ven interrumpidos cada día porque ellos o alguien cercano a ellos se ha infectado recientemente. Y su infección puede conducir a una enfermedad grave. Dada la naturaleza impredecible del virus SARS-CoV-2 y los cientos de miles de residentes en el condado de Los Ángeles que continúan teniendo un riesgo elevado de infección y posiblemente una enfermedad grave, recomendamos o es altamente recomendable que todos continuemos trabajando juntos para frenar el contagio. Todas las estrategias de prevención comunitaria en nuestro plan de respuesta posterior a la oleada nos ayudarán a reducir la transmisión. Sin embargo, con una dependencia mucho menor de los requisitos de mitigación, las vacunas asumen un papel más importante en la prevención comunitaria. Esto se debe a que las vacunas ofrecen mucha protección a las personas que se vacunan y a quienes están alrededor de esa persona vacunada. Las vacunas son una forma segura de desarrollar inmunidad individual y comunitaria y sin enfermarse o correr el riesgo de enfermarse gravemente. Si bien la infección previa brinda una protección real, se desvanece con el tiempo y es más seguro vacunarse después de la infección que volver a infectarse. Finalmente, es interés de todos reducir las posibilidades de que este virus se transforme y esto se logra fácilmente disminuyendo el número y la propagación de infecciones. Por lo tanto, si no está completamente vacunado o le falta su refuerzo, incluso cuando el número de casos está disminuyendo, este es un buen momento para hacer esa cita o visitar uno de los cientos de sitios convenientes en todo el condado donde puede obtener su vacuna o el refuerzo de forma gratuita. Agradecemos los esfuerzos de todos por mantener este impulso negativo a medida que implementamos nuestro plan posterior a la oleada. Y gracias. Y ahora ya no tenemos más información y nos veremos hasta la próxima ocasión.
Thank you so much, Monica, and thank you to everyone who joined us today. For media questions, you may send them to our media inbox. You can find that at media@ph.lacounty.gov. Once again, thank you for joining.